Thank you very much for the introduction. It's my task to take a look in the future, which is difficult, as you know. These are my conflicts of interest. But nevertheless, I made a selection of some promising things. I will not be comprehensive. I will focus on immunotherapy, on stem cell inhibition, and on a modifier of inflammatory microenvironment. And you will see there is some promise in the future, which is good after the failure of anti-MET, anti-EGFR-directed approaches, and some others. I do not really need to introduce you to the principle of immune checkpoint blockade. You all know the PD-1, PD-L1 axis has been investigated in phase 1b, phase 2 trials in gastric cancer, and we just a couple of days ago saw the full publication of the first study that investigated pembrolizumab, a PD-1 inhibitor, in patients with advanced metastatic and pretreated gastric cancer, the KEYNOTE-012 study. And as you can see on the waterfall plot, more than 50% of the patients achieved any decrease in target lesions, and the objective response rate was 23%. And what is probably more intriguing even than these numbers is that many of these responses are of long duration, as you can see in the swimmer plot. So this is probably a good sign. The same is shown by these spaghetti plots, and there is one challenge also in clinical practice. It's those patients who have a progression first and then go into remission, what today we call pseudo-progression. It's not a very common phenomenon, but it exists also in gastric cancer, as you can see on this plot. And I think this is still a challenge because it's something where we have to take a decision when a patient is progressive after 8 weeks. Can we go on or not? It's a tricky question. Of course, biomarkers matter, and many correlations are currently done with PD-1 expression, and you know there are some data in melanoma different from lung cancer and also probably different from gastric cancer. At the bottom line, we can say there is no threshold yet for PD-1 expression under which you can say a patient has no chance to respond to this treatment. So even in patients with a very low PD-1 expression in tumor or tumor stroma, there still is a chance that a response occurs or a stabilization occurs. So probably this is not the biomarker to go, or at least not the only biomarker to go. The group of investigators in KEYNOTE-012 also looked at the expression level of different genes which are involved in immunoregulation, but they did not see any difference between responders and non-responders. So the next question in this field is now, does it make sense to immune checkpoint inhibitors, anti-CTLA-4 together with anti-PD-1? And new results have been shown at this year's ESCO meeting about this approach, has been shown by Jelena Janjigian from New York. It's a 3-arm phase 2 study. One arm of patients received nivolumab alone, the other arm nivolumab and ipilimumab, and another dosage of nivolumab and ipilimumab in the third arm. I would like to focus your interest on the middle arm, nivolumab 1 milligram per kilogram plus ipilimumab 3 milligram per kilogram. This is the waterfall plot which looks most promising. Most responses, or more responses, have been seen in this arm than in the 2 other arms. And again, we can say there is no threshold of PD-L1 expression that is clearly predictive of response. Maybe it is interesting that in the group of patients with a very low PD-L1 expression, there are some more responders in the nivolumab ipilimumab arm, which might confirm the concept that ipilimumab contributes to the immunization of the tumor, then nivolumab has a better chance to work. But this is very preliminary at this stage. Of course, the combination of the 2 inhibitors leads to increased toxicity. You can see grade 3-4 toxicity, 17% in the nivolumab alone arm versus 45% in nivolumab plus ipilimumab. This is something we need to take a close look in the future. On the poster that has been shown, there was one example of a super responder, and interestingly, this super responder has had a deficient DNA mismatch repair system, which may bring up the idea that this group of tumors with a deficient mismatch repair system or MSI high status might be patients who have a particularly good chance to respond to immune checkpoint inhibitions. This brings us to what Adam Bass showed earlier on this morning, that maybe within the subgroups of TCGA, we will be able to identify subgroups with a more susceptible tumors to immunotherapy. EB1 and MSI-associated tumors have more immunoinfiltrates, have higher levels of PD-L1 in the tumor and tumor stroma. Maybe these are particularly good candidates for this kind of therapies in the future. So the conclusion for checkpoint inhibition is we have promising data on PD-1, also on PD-L1 inhibition. I haven't shown you the data on avelumab. Objective response rates are between 20 and 25% in highly pretreated patients. Some responses are of long duration. A double blockade of PD-1 CTLA-4 looks even more active, but increased side effects with the double blockade need to be taken into account. Selection of patients on the basis of biomarkers is yet unclear, and multiple phase 2 and phase 3 studies are ongoing. So I changed the topic, but I stay in the field of immunotherapy, and I would like to introduce a new drug target, which has been shown for the first time on a big congress at the ASCO meeting just a couple of weeks ago, and this target is called Claudin 18.2, and as this picture shows, it is a tight junction protein. The group of investigators around Ugo Sahin and Özlem Türeci from the University of Mainz have identified this new splice variant from the Claudin 18 family. Claudin 18.2 is a member of the Claudin family. It's a major structural component of the tight junctions. It is broadly expressed in various cancer types like gastric cancer and some others. And importantly, it is not expressed in any healthy tissues except for stomach mucosa. This can be an advantage when you think about off-target effects, but it is expressed in healthy stomach mucosa. And they have developed a diagnostic antibody, but also a therapeutic antibody, which is called IMAP362. This is a chimeric IgG1 antibody, which is highly specific for Claudin 18.2. And the modes of action have been identified to be basically antibody-dependent cellular cytotoxicity, ADCC, and complement-dependent cytotoxicity, CDC. And the first results from a randomized phase 2 study in first-line metastatic gastric cancer in combination with chemotherapy, which was epirubicin, oxaliplatin, and capecitabine, have been presented at ASCO. You can see it's a 3-arm phase 2 trial. One arm received chemotherapy alone, second arm chemotherapy plus IMAP362. And the third arm received a higher dosage of the investigational compound. The results which have been shown are mostly based on the first 2 arms, chemo versus standard dosage of the monoclonal antibody. The primary endpoint of this study was progression-free survival, and as you can see on this slide, progression-free survival primary endpoint was significantly increased by the addition of the experimental compound. Median progression-free survival 4.8 months versus 7.9 months. As a secondary endpoint, overall survival was also reported, which was also increased from 8.4 months median to 13.2 months median. This is very promising indeed. And I would conclude at this stage, IMAP362 is a monoclonal antibody directed against Claudin 18.2. It is an emerging drug for first-line treatment of metastatic gastric cancer in combination with chemotherapy. The target assessment with Clauditect looks robust. I haven't shown you the data. PFS and OS have been improved in this phase 2 setting. The treatment was feasible, but vomiting is a critical issue. I haven't shown you the data, but this is the main side effect of this antibody. and a validation of the study results from FAST in phase 3 is planned. So I switch to another topic. It's cancer stem cells. And is there anything emerging in this field? This is the stem cell concept. When we give conventional treatment like chemotherapy, we decrease the bulk of the tumor, but the cancer stem cells are not chemotherapy sensible, so they will ultimately lead to progression and relapse. If we give a stem cell inhibitor alone, probably debulking of the tumor is too slow. So the concept would be to combine both conventional chemotherapy and a stem cell inhibitor. Do we have stem cell inhibitors? This is a broad field, but meanwhile we know that STAT3 signaling is involved into cancer stemness. And there is a new compound which has been developed by a company in Boston. It is called BBI-608. This is a small molecule that inhibits genes transcription driven by STAT3. So it leads to a decrease in cancer stemness genes and to a decrease in immune evasion mechanisms. At least in theory and in the experimental setting, there have been promising phase 1b/2 experiences, which I do not show you. I just show you the design of an ongoing trial, which is done in the second-line setting of metastatic gastric cancer, combining this anti-STAT3 compound, which is called BBI-608, with paclitaxel, and the standard arm is paclitaxel alone. Recruitment goal 680 patients. This is an ongoing study which will recruit until the end of this year. And the last new principle I would like to show you has been presented by Manish Shah on a poster at this year's ESCO meeting. It's about modification of the tumor micromilieu by inhibition of matrix metalloproteinase 9. MMP9 is a molecule which is important for the progression or integrity of the micromilieu. It has an influence on endothelial cells, but also on fibroblasts and also on the inflammatory filtrate. It's a very complex interaction. In the preclinical setting, it has been shown that treatment with an MMP9 inhibitor leads to a decrease in fibrillar collagen in tumor tissue and also to a decrease in tumor cellularity. And so we come already to the first data in humans that have been presented as a phase 1b result. And here is the objective response rate. If you combine an MMP9 inhibitor, which is called GS5745, which is a monoclonal antibody in first line or second line with FOLFOX, and it has been reported that a relatively impressive objective response rate of 55% with this combination can be achieved in treatment-naive patients. 3 complete remissions have been reported and 13 partial remissions. Of particular interest, again, is the duration of response, which has been reported to be 10.6 months median. And another interesting number is the median progression-free survival to be 12 months in treatment-naive patients. So this is also an interesting compound which will be taken to phase 3. So let me summarize. For immunotherapy, we can say that anti-PD-1 alone or in combination with anti-CTLA-4 shows promising activity in phase 1-B. Anti-Claudin 18.2 directed antibody IMAP362 indicates good activity in combination with epirubicin, oxaliplatin, and capecitabine in phase 2. As stem cell-directed therapy, we have the anti-STAT3 molecule, which has shown promising activity in earlier studies and is now investigated in phase 3. And as a tumor microenvironment modifier, we have MMP9-directed treatment by GS5745, which shows promising activity in combination with FOLFOX in phase 1b. All approaches I have shown you are currently studied in phase 3 or are planned to be studied in phase 3. I thank you very much for your kind attention.